Did you know that there are 6 main factors that accelerate aging? Clinical pharmacists are the expert when it comes to managing one of them, which is medication. Now, when your medication is correctly managed, it's been proven to help you age better and live longer. I'm Hannah McQueen, founder of Brightly, a service designed to help people age well and stay independent for longer.
And I'm Marc Leishman. Now, this podcast, The Next Bit, sits alongside Brightly, helping make sense of ageing in plain English and hopefully easy maths. So let's start with some stats. According to a study published in the New Zealand Medical Journal in 2020, almost every Kiwi aged 65 and over takes prescription medicine. That's 91%. And 35% take 5 or more long-term medications. Lead clinical pharmacist Julia Brooks specialises in medicine optimisation with older people and joins us to unpack this complex topic.
Julia, thank you for joining us. We're going to pick your brain on all things to do with medication, because when we think about ageing, it kind of seems to go hand in hand that we're going to be taking more medicines. Is that true?
Hopefully not, but I mean it is for some people. But the problem with medications is as you age you become more sensitive to them. So the more medications you're on, the more likely you are to get side effects and have harm. So the ideal is to be on the least number of medicines that are doing just the right job. It's not about numbers.
So you're a clinical pharmacist. Can you describe what that actually is?
Yeah, good question. Most people don't know. So obviously, people have heard of their pharmacist,
Yes.
their community pharmacist. That's the person people most attribute with that term, pharmacist. A clinical pharmacist is somebody generally that has done additional postgraduate study and works as part of a multidisciplinary team, so with doctors and nurses in a sort of collaborative environment. Traditionally, that was always hospitals, but more recently, clinical pharmacists are now working in primary care with GPs and as part of that collaborative team. And then there's also pharmacist prescriber, which is another kind of level of postgraduate experience where you can actually prescribe like a doctor and manage sort of long-term conditions. It's like the pharmacist equivalent to a nurse practitioner, which people have heard of. So there's different levels, but clinical pharmacists have that additional kind of focus on not just is the medicine prescribed appropriately and is it right for the patient, but does it optimise the patient's outcome? Is it the best medicine for that particular patient? What about tricky interactions? How do you cope with their declining renal function? All that kind of stuff.
So you're starting to use words I don't even understand,
Okay.
so that's great. So I'm just going to back this truck up a bit.
Yeah.
So if we think of a pharmacist versus a clinical pharmacist,
Yep.
because I wouldn't have even known there was a difference. So you're saying that the clinical pharmacist is able to prescribe, they work with a multidisciplinary team, which to those of us who aren't clinical, that's a team made up of other different specialties, doctors, sometimes physios, nurses, kind of there's a group of you coming together to look at one particular patient, which sounds pretty awesome. You're a clinical pharmacist.
Yep. So there's pharmacists, so your basic or entry-level sort of community pharmacist, clinical pharmacist, and then pharmacist prescriber in terms of layers of experience and qualifications. And it's sort of similar to, not the same, but similar to sort of GP, advanced trainee, and then like a specialist, like a cardiologist or a geriatrician.
Zones in on a particular area.
Yeah, exactly. Yeah.
And from your perspective, you've got this interesting add-on where you specialise in optimising medications for older people. Is that right?
Correct. So I was a clinical pharmacist working in a hospital environment for many years, and I did all the basic level training, moving around the different wards, learning a bit about everything. And when I discovered my passion, which was older adults, because they're so much more complex than, it's not just one problem, it's all the problems. But there's also so much you can do to help people in that in final age. Medicines cause so many issues. There was a lot I could do, a lot I could give, a lot of things I could make a difference. And so I specialised in the sort of older adults field of pharmacy with a focus on optimising medication. So trying to get people on the right medicines for them at whatever stage of life they're at.
Are you dealing with individuals, or are you dealing with is it more a corporate thing, or the overall, or the umbrella?
So when I was working at the hospital in that scope, it was individuals that came into the hospital as part of the older adults ward. I would be reviewing their medicines as part of that hospital stay. Now my primary role is actually in primary care. So I work in a GP practice and I see patients on a daily basis. But a significant number of those are referred to me by the GPs for medicines optimisation. So while my background is geriatrics, I see any adult patient now, but my patient is still very much that older adult.
Can you tell us what a medication review is?
Yeah. So when a medication review is essentially making sure that the medications that you're taking are still appropriate, necessary, that you're taking them at the right time, at the right dose, that there isn't any interactions. And there's different levels of medication review. So there's something called a medicine use review, which really just focuses on, are you taking it as prescribed, and do you know what it's for? And maybe are you getting side effects? But a medicine optimisation review is kind of the next level, and that's looking at the whole picture. Not just are you taking it how the doctor said, but is it even the right medicine? Is there a better one for your condition given your complex personal situation? What are your personal goals? And do those medicines align with those goals? Are we missing any medicines? Is there something we could be doing actually to make your health better, as opposed to just, are you taking what's been prescribed right? Pharmacists are the medicine specialists, and we often know and contribute more than, say, a GP in terms of why you choose one medicine over another to treat a particular problem.
That might be new information to a lot of people, that the clinical pharmacist might know more about the medications than the GP, because often we're thinking the GP is the
absolutely,
the author and finisher.
Yeah, absolutely. And often they are, unfortunately. So one of the issues that, I've felt quite frustrated by over the years is that until very recently, the only place you could come across a clinical pharmacist was in the hospital, which meant that if a GP wasn't sure how to transition a patient from this drug to this drug, or the patient was having a particular symptom and they couldn't really unravel, could this be a drug side effect? There was no one for them to ask. The clinical pharmacist, or access to a clinical pharmacist, was bottom of the cliff. You had to end up in hospital already.
Right.
Yeah, which we struggle with, that reactive, fragmented care. It grinds our gears a bit, to be honest.
Absolutely.
So if we wanted a medication review, firstly, is there a number of medications you should be on before you would consider a medication review, or is it actually you should get this reviewed independently, especially if you've been on some of these things for a while? Like my granddad is on medications. I don't even know if they're appropriate for him anymore, and he's been on them
doesn't
since
know either.
Adam was a cowboy.
Yeah. So the short answer is, if you're on one or more medicines, the question should always be, is this medicine still appropriate and still necessary? But the key where we know that risk increases is where we hit a threshold of 5 or more sort of regular long-term medicines. And we in my field, we call that polypharmacy. So many pharmacy, pharmaceuticals. So many pharmaceuticals. There is various definitions, but the most common is 5 or more regular meds. And at that point of 5 or more regular meds, the risk of interactions between those meds increases, the risk of side effects increases, and there's also a 75% increased risk in falls in an older adult on 5 or more regular medicines. So that if there's going to be a threshold, that would be it. But before that, if you don't think the medicines are working for you, if you feel unwell and you're not sure why, if you think you might be getting a side effect, or you just don't know what they're for, all of those are good triggers for a medication review.
And I learned from personal experience. I was on medication, and my doctor told me to take it in the evening before I go to bed. And of course, I'd sometimes forget, and I'll just take it in the morning. And then I'd wonder why I'd start sort of falling asleep at 11 o'clock. I mean, that must be a thing. If you've got 5 medications, that some would obviously, with you say side effects, make you a bit drowsy or whatever.
Absolutely.
It's so important to follow that advice and don't deviate from what they tell you.
And the more medications you're on, the increased complexity of the regime, the more likely you are to run into challenges. Because if you're only on one pill and you know to take it at night and you
We
figure
didn't
out...
even know how to do that.
Exactly.
Come on.
Well, I knew we should, but and then you figure out it's making you sleepy. Well, then the next question is, if I do forget it, do I just skip it or do I take it despite
exactly.
How do I manage those,
Take
those,
2 tomorrow.
yeah, well, exactly. How do you manage those inevitable kind of bumps in the road that happen because you're human? And more than that, the more complexity you've got in somebody who is aging and may have impaired sight or impaired hearing, or even their cognition is not what it used to be. The more complex the regimes, the more likely they are to forget, the more likely they are to get muddled, the more likely, all of those things.
Yeah.
It is interesting, your point on the falls risk. So if you're taking more than 5 medications, 75% more likely to have a fall, which then kind of feeds into, if you are truly assessing the risk of falls, you can't just be linear in focusing on whether you're balanced or whether you need to improve your strength. Like, it's almost, what's the point of working on that if your polypharmacy is up the wazoo? Like, that would just kind of
Undermines
counterintuitive.
it. Yeah. I mean, so there's multiple things that contribute to falls, and you've just named a couple of them. Your balance is one, and your strength is another. But your cognition is one. If your vision is one. If you can't see well, you're going to trip on the rug or trip on that cord. If you can't, if your balance is off, and you turn too quickly, you hit the deck. And medicines impact all of these things. Medicines can cause blurred vision. Medicines can cause balance issues. Medicines can make you drowsy. And if you're getting up to pee at 2 a.m. and you're half asleep at the best times, and now you're on a pill, you're more likely to trip on something, or So they all feed in. But medicines in older adults are a huge contributor to what we call morbidity, or health issues, and not just falls, hospitalisations, and even death. So the more pills you're on, the more likely you are to end up in hospital, or have an adverse reaction that could cause something really significant.
How hard is it to get a medication review?
Unfortunately, very hard.
Unless traditionally, like I said earlier, if you're admitted to hospital, you might get a medication review if you're lucky. If you're lucky. And I say if you're lucky because if you're admitted to a surgical ward because they think you've broken your arm and you've had a fall, if they assess that arm is not broken, you're out the door because they need the bed for someone else. You're unlikely to get a medication review in that context. If you're lucky enough to have a community pharmacist that can do something called a medicine use review, which is that sort of, are you taking the medicines as prescribed? Then you may be able to access it, but many pharmacies do not offer that service. And that's not talking about how the medicines interplay with each other. It's just like,
that's just
basically
prescribed.
Are you doing as you're told?
do you understand to take it at night, Mark? Yeah, so he got that done, and still.
Well, I learned the hard way, and I know I've never failed now.
Yeah, well, and that's it. And often, unfortunately, that's the bottom of the cliff. People only learn that they're doing something wrong because something goes wrong. So the next level is now, at the moment there's a what we call a pilot going on, so a trial of putting clinical pharmacists like myself into GP practices to try to increase access to people like services like this. But there's not that many around, and you'd have to be pretty lucky to end up in to be in a practice where they've got a clinical pharmacist. So up until about 2 months ago, there was, for most people, no way they could get a complex medication review. Brightly now offers these as a pay service. It is currently privately funded, but I'm really excited about it because it's the only avenue that you've got if you are wanting to have this done. If you know that something's not right and you want a second opinion that isn't the doctor that prescribed it, somebody independent who's a specialist in the medicines, come and see us.
Yeah.
One of my observations through discussions with doctors is sometimes they inherit a patient and they've got pre-existing conditions and pre-existing medications. And sometimes the doctor doesn't know the detail behind what triggered that prescription. And so it's almost like the prescription gets carried forward. And everyone seems to be a little bit scared to take someone off a prescription
Absolutely.
or off medication. So we're saying that this medication review, because you are the specialist in the room, you're able to actually assess whether those drugs have been replaced with better drugs or whether actually the side effects are creating greater risks than what the drug itself is trying to address. Is that fair?
Absolutely. Or whether the medicine's even necessary. So a good example is patients that have arthritis in their knees and hips and they're in constant pain. When they're in their 50s and 60s, they might take anti-inflammatory painkillers to treat that pain. Those medicines are really hard on your stomach, and so you end up being put on something called a proton pump inhibitor. People have heard of Losec and omeprazole to protect the stomach while they're using these painkillers. Now, fast forward 5-10 years, they've had double knee replacements. They don't have arthritis anymore. The anti-inflammatories have stopped, but that proton pump inhibitor is still going. And that medicine is associated with increased risk of fractures, increased risk of pneumonia, increased risk of electrolyte disturbances, nutritional deficiencies, all kinds of problems, but it's so ubiquitous in the population because the GP doesn't know, well, was it started because they had a stomach bleed, or was it started because they were taking loads of anti-inflammatories? And they don't have the time to sit down and go back 15 years in somebody's medical record to find that out, and quite often the patient doesn't know themselves. So it requires somebody who's got the time and the know-how to do a bit of sort of forensic investigating. When was the medicine started? What was happening at the time? Were there hospital admissions? Have there been tests done? To build that confidence to decide, actually, we should try withdrawing that.
Is there something that you wish older people knew about pharmacists and about their medicines?
I mean, about pharmacists, we love to help. Pharmacists, across the board, I hear people say, they go into their pharmacy and the pharmacists always run off their feet, and that's true. They're busy people, and same in the hospital. But we want to talk to you about your medicines. It's our passion. It's our, it's our bread and butter. So we want you to ask questions. We want you to be interested. It's, frustrating when people come in to see a pharmacist, whether it be in a hospital or in a community setting, and we want to talk to you about your pills, and they're saying, I already know. It's fine.
The doctor says it's fine. It's fine.
I don't need any additional information, because they almost always do need additional information. They just don't know what they don't know.
Can you give an example of what sort of additional information that a pharmacist would?
Absolutely. So I actually had a patient yesterday who I recalled to come and see me, and he was, had been quite pushy and said, I know my body, I just need a repeat of my usual medicine, and I please just do me the service of coming to see me. Anyway, I sat him down and I started to explain to him about one of his conditions, not the one that he thought we were going to talk about, but he has a history of gout. And I was explaining to him that he's not on a medicine for gout, and so he's going to continually keep getting flares. And he said, yeah, but, the painkillers work and I carry on. And I said, are you aware that what's happening is that the crystals that cause the flare are building up in your joints and actually are damaging those joints?
It's going to get worse.
Well, actually permanently damaging and causing arthritis. Turns out this fella's a concert pianist.
Oh,
and he showed me his hands, and he had deposits of uric acid, which is what
you could see them.
I could see them, and his fingers. Nobody had ever explained it to him, ever. And so suddenly he's like, what do I do? So he didn't know what he didn't know.
Yes.
Yeah.
And afterwards he was shaking my hand. He was so happy. But it's just making sure that you educate people so they have the right information, and never underestimate the stuff that you possibly just don't know that you don't know.
Can you fix him? Is he going to be able to play the piano?
Yeah, absolutely. We
You better
started
put it
him
right.
on the right medication, and this is a man who said, I only need to come in once a year just for a check-in, and now he wants to see me every 6 weeks until we get him to target, and we know.
Perfect.
So yeah.
Great stuff.
wow. So what are the challenges for people who are on longer term medications?
There's a number of them. I think the biggest one is how do you decide or work out whether or not they're all still necessary? And there is the assumption that the GP is doing that, but in a GP consult, you've generally got 15 minutes, and in that 15 minutes, you're usually coming not just to talk about your long-term medicines, but the sore on your toe or the thing in your ear or
It's
the
probably
rash
something that's got you there.
Exactly. And, GPs tell people, pharmacists tell people, you should be booking a review just to talk about your long-term medicines. But it's expensive to go to the GP. And so that almost never happens. And so you don't get that really kind of focused discussion about what are these pills for? Why am I taking them? Are they all still necessary? And what are we trying to achieve here? Like, what is my target? What am I aiming for? Because if you don't have that information, how do you know if you're winning? How do you know if the risk or benefit is, working in your favour?
But the target would be obvious, wouldn't it? You want to get better, or you want to get relieve pain, or you want to...
What's your target blood pressure for someone of your age?
I'd say, is it 130 over 60 or something?
Close, yeah. Not bad. So, but that's one example. Yeah. So generally 120 over 80, up to 130 if you're getting older, we're a bit looser. That's one example. But there's targets for everything, for certain blood levels, for certain chemicals in the blood. And we know that, for example, if you can reduce your cholesterol from this to this, we can reduce your risk of having a heart attack by 25%. Do you know what number you're aiming for? Are you achieving that number? If you don't know what the target is, then you can't say to the doctor, hey, look, I'm not achieving my target, so, should we up this medicine? You can be proactive if you have more knowledge.
See, it's helpful to cut across all components of health then, right? Because it's almost, if you look at something in isolation, yes, your blood pressure might be right, but what about all these other things that you've got no clue about, let alone what you should be aiming for?
Absolutely. And you said the other day, earlier, what are the challenges? And we talked about multiple doctors and different doctors having started things. One of the biggest drivers of polypharmacy, being on multiple medicines, is multiple prescribers. So if you're somebody who's got complex health needs and you have a renal doctor or an endocrinologist and a cardiologist and a GP who's trying to coordinate all of this, and this GP is getting letters from one doctor saying, for my specialty, I want you to do X, Y, Z, and then the other one is saying, well, I want you to do X, Y, Z, and the GP's got to try to filter this out and work out how to combine all these things. And as a GP, if you've been if the specialist has said we need to do this, a lot of GPs are really reticent to, overrule that specialist advice, but often it's not appropriate. And I love a good patient story. So just another example, I spoke to a gentleman a few weeks ago whose wife has end-stage Parkinson's disease, and she falls over all the time because her blood pressure is so low because her body just can't coordinate it anymore. It's just given up that ability to, regulate it. Now, she also has a history of heart problems, and her cardiologist had said, oh my gosh, you can't be on that drug. It will push you into heart failure. But this woman without that drug is blacking out because her blood pressure is so low. And so, he was looking at it very much through his lens, without looking at the wider, holistic, what's best for this patient at this moment. And again, that's where a medication review comes in, because we're not looking at a narrow lens, we're looking at the whole big picture.
What about signs that your medication might not be quite right? Because I think one of the things that we've come to appreciate is that as we're getting older, everything's changing. Your body systems, your organs, it's all changing, and how they interact with each other is changing. So I'm assuming there's an example where a medication's worked really well for you based on where your system is at that point, but as you're getting older, maybe less so, or it's changing how effective it is. What are some earlier signs or just symptoms, indicators that, hey, we probably should do a medication review, outside of the fact you're on 5 medications or more, which should almost be a compulsory?
Absolutely.
It's definitely compulsory in Brightly, isn't it?
That is, absolutely. Yeah. I mean, every patient that we've supported through Brightly has benefited from having their medication reviews. There's there'll be the odd patient who's only on 1 or 2 medicines, and maybe a supplement or but for the most part, almost everyone can benefit from. And to be honest, even if you're not on that many meds, maybe you should be. That's the flip side of it too, right? It's not just about because when we talk about polypharmacy, we're really concerned about inappropriate polypharmacy. Sometimes it's appropriate and it's needed. So the signs that something might be amiss. In an older person, I've got this favourite quote, which is, any new symptom in an older person should be considered a drug side effect until proven otherwise. So if you suddenly are getting dizzy, if your memory's not quite as good, if you've got a dry mouth, or you're constipated, or you're having to get up to pee 4 times, 5 times a night where before you didn't, you're unsteady on your feet, you've had a fall, you're not sleeping well, your mood's low, all of those are potentially drug side effects.
Wow.
Which is weirdly reassuring.
Yes.
Because if you have the right person looking at it, you can actually intervene.
Correct. Yeah, absolutely.
So, Julia, how does ageing change the way our bodies react to medications?
Right, it's a really good question. There's multiple ways. The most significant is that your brain becomes more sensitive to medicines. So medicines that act in your brain, so things like sedatives and painkillers, your brain becomes less able to cope with them. Side effects become more profound, and they cause more harm. So that's the first one. The second one is that the way your body processes medicines changed. So as you age, your kidney function slows down, and your kidneys filter medicines out and get rid of them. So as the kidney function slows down, we need to reduce your doses of some medicines so that you don't end up on too much. Your liver is like the factory that breaks down unwanted medicines in your system, and your liver function reduces as you get old as well. So we need lower doses or less frequent use of some medicines to make sure that they don't build up in the body and end up, causing harm from essentially low-level overdose. The other thing is your own body composition changes. So as we get older, unfortunately, for most people, your muscle mass reduces and the fat tissue increases. What that means is that the amount of body that fat-soluble medicines have got to float about in increases, and the amount of body that what we call the volume of distribution for water-soluble drugs reduces. And so again, if you're on the same dose as you were 20 years ago, but the actual amount of muscle that you've got is much smaller, you're concentrating that drug in a smaller sort of container, so it's more potent. And so again, it can have a profound impact on that way that medication works. It can mean that the effect of the medicine lasts longer in the body. But the most significant for me personally is the impact on the brain and the fact that you become more prone to what we call central side effects. So things like sedation, confusion, blurred vision, balance problems, forgetfulness, instability, all of those kind of central brain functions get dampened, and you can get increased risk of side effects from medicines that work in the brain.
Are there common medications that people over 50 should perhaps avoid or use with caution?
Absolutely. So there's some common groups, and I'll rattle them off and then talk to a couple of them. So the first is opioid painkillers. So that's codeine, tramadol, morphine, oxycodone, and to name the most common ones. These are associated with impaired cognition and a whole raft of side effects in older people. And a higher incidence of falls. So opiates are one of the highest classes of medicines associated with contributing to falls in older people. The next is sedatives or sedative hypnotics. So essentially sleeping pills or anything that makes you sleepy. For just that reason, if you're a bit sleepy and not quite with it, you're much more likely to trip, to have poor balance, to fall over. If you fall, you hurt yourself, you end up in hospital. It could be really significant. And they also impact your cognition. So things like anti-anxiety medicines, known as benzodiazepines. So people will, the Valium of old, or lorazepam, diazepam, we know that their use is associated with a higher likelihood of having dementia as you get older. They don't necessarily cause it. The jury's still out, but we know that people with cognitive impairment have often been on these medicines. We just can't prove that it's a cause and effect thing yet. Diuretics. So they're the medications that can make you pee, because they can. As you get older, your body is less able to regulate your kind of dehydration status, and you stop getting messages to feel thirsty as you get older. So you more easily get dehydrated, and if you're dehydrated, then your blood pressure drops, you feel woozy, lightheaded, you're more likely to fall. So there's quite a few, but often if it works in the brain, it's likely to be a problem. You know, I actually had a patient, a week or so ago who has been on long-term opiates for chronic headaches, and is also on amitriptyline and was started on that for headaches many years ago. She's on a massive dose, a really big dose. And I called her in to see me to talk about her medicines. And she was so anxious and so distressed, and started the consult really closed off, really keyed up, basically saying, you're going to try and take my medicines off me, and, I need these, and I can't, I suffer without them. And I said to her, I'm not taking anything away. What I want to do is talk to you. I just want to educate you. I want you to understand your condition and what might be happening so that you are making informed choices, and that is all. And so she started really defensive, didn't actually want to talk to me. I had to push and sort of insist. By the end of the consult, she was hugging me and saying thank you, because she had been empowered. She'd been empowered with the knowledge to make informed choices about what was happening to her and what she was putting in her body. And that's the key. That's the key for a medication review, is empower people to make choices that work for them.
It is interesting because a lot of us, I don't know about you, Mark, but I would have assumed that my GP would have told me that information if I needed to know it. Back to that point you said earlier, that when you don't know the things you don't know, there almost isn't this recognition that the GP doesn't have time to do it. Even if they wanted to, they don't have necessarily the capacity or the clinical specialty to go through a whole lot of drugs. Is that fair to say that?
Yes, but it's also entirely possible that the doctor did say it. The literature out there tells, and there's really good studies to prove this, people remember about 10 to 20% of what you tell them in a consult.
Well, when my doctor tells me something I don't want to hear, I immediately forget it.
Right?
So, yeah.
And so you're just normal,
But also, they say, there could be side effects about this, and you kind of forget about that too.
Yeah, true. You're quite dismissive of it.
And that is particularly true if you're dealing with something that is emotional, like pain or poor sleep, or something where there's a lot of anxiety attached to it. Absolutely. You are looking for a solution, and the doctor is the gateway to a solution, right? You don't want to hear that it might cause other problems, particularly not when you're there that day with your terrible pain, or you haven't slept in 3 days, whatever it is. And, often doctors are put in this position where there's an expectation that they will prescribe something, even if they know actually that the answer is something else. Often patients can be quite assertive. Let's go with assertive about, I need something, you must help me, you must prescribe something, when actually the solution might be much more difficult for the patient. Lifestyle changes, meditation, physio, exercise, something much less glamorous than taking a pill and it solving the problem. But so GPs end up in a position where they have explained these things, but the patient doesn't remember, or they've warned the patient, but that was 10 years ago. Or as we said earlier, the GP that you're dealing with now has actually inherited you on these medications, and he doesn't know what you know. And in 15 minutes, his job or her job is to, make sure that it's safe and appropriate and working, not necessarily to do a deep dive into, is it still the right medicine? What was the reason it was started? Unless you book a consult just for that, that won't happen.
So that's really what you're saying. That's the biggest issue for people, is that they're on long-term medications. The chances are that they probably don't need to be on all of them.
Correct. There's probably one or two that should be reviewed. And the problem, if you step back further from that, the problem is that people don't know what they're on and why they're on it.
Yeah. They just know to take it.
They just know to take it. If you, if you can't even, if you don't even know what your medicine's for and what the expected effect is and what the expected side effects are, how can you advocate for yourself? How do you know what to look for to make sure it's working, or you're getting a side effect if you don't know what those things are?
Are there any supplements that you'd recommend people take as they age?
The short answer is no. And there's a reason for that. If I was, supplements are expensive, and the evidence for them is mostly pretty wishy-washy. They'll do what we call clinical trials, where they'll put one person on a sugar pill and another person on the actual medicine and watch what happens. And that's the gold standard sort of way to do it. And those trials and supplements almost don't exist, because you can't patent a supplement like you can a medicine, and these trials are incredibly expensive. So the quality evidence to prove these things work doesn't exist. When there is trials, they're small, because again, it's not like a pharmaceutical company where they can get their money back for to prove that their product works. You can't patent magnesium. You can patent a formula, but if you do a big trial and prove that magnesium helps with your night cramps, for example, everyone else can just jump on the bandwagon and start selling magnesium. You can't make any money out of it. So what would incentivize you to do a big drug trial? So does that make sense?
It does, but the inverse, just because they haven't done the trial, doesn't disprove that it's effective because they haven't trialled it.
Absolutely. And therein lies the problem, though, because there's a huge amount of placebo effect with these things. We know from really good quality trials that if I give you a sugar pill and tell you it's going to do X, Y, and Z, it will actually do that.
I'm definitely a placebo girl. Yeah, you could tell me anything, just give me a pill and I'm working.
And it's even worse, the more invasive the treatment. So if I inject you with some salt water, it's more likely beneficial than if I just give you a pill, because it's more invasive. You're more invested in it working, and so it's more likely to work. So there's a huge element of placebo effect with some of these things. Actually, my personal opinion is where there is lots of good evidence, particularly for slowing aging and particularly cognitive aging, is exercise and nutrition. Really good quality nutrition. So rather than taking a fish oil supplement, treat yourself to salmon once a week. Spend your money on eating quality nutrition and getting physically active in a way that's safe for you.
So that's omega-3, isn't it? Is it?
Yeah,
So
absolutely.
have your salmon, don't take the pills.
He's off again. What was that, Dr. Leishman?
So, the thing with is there is evidence for certain nutrients that they are beneficial, but they tend to be beneficial in very small group. The evidence is they're beneficial in very small groups of people. So if you've got a particular set of problems, there might be evidence that it's helpful for you. But for the majority of people, it's unlikely to do anything.
Right, so that possibly comes back to your earlier point that if you know the target or the target range you're looking at for a particular vitamin or mineral,
correct,
because you can track those,
yes,
then targeted intervention or an extra supplement might pay, but in general, just taking a supplement for the sake of it might not actually move the needle in any direction of benefit.
And then there's the added issue of interaction. So medicines can interact with herbal supplements and nutritional supplements. If we use the omega-3 example, so at high doses, omega-3s thin the blood. And they thin the blood at doses 2 to 3 grams a day, so that's often 2 big capsules. They can thin the blood to the same degree as an aspirin or a baby aspirin. Now, if you're already on a blood thinner and then that blood thinner is having an additive effect with that supplement and you are then covered with bruisings and getting bleeding noses and potentially, becoming anemic because of it, that supplement is doing more harm than good. And that's one example, but there are many, many examples.
What would be the must-dos when it comes to medication?
The must-dos. Take it as prescribed. I'm looking at you.
Yeah. Sending the message.
Yeah. Take it as prescribed. Know your medicine. Know what it's for. Learn how to pronounce it so that you can ask questions about it. They all have these crazy names, right? But when you break the names down, they're often not that difficult. It's just a mouthful when you're learning them. Learn what your medicines are called, what they're for, and what they're trying to do. And the next step is make sure that you're taking them as prescribed. Read your label. You'd be amazed how many people don't even read the label on their bottle. I had a fellow a few weeks ago who was referred to me by the GP because I was told he didn't feel his medicines were working and he just didn't feel well. And the first question I asked him was, when are you taking your pills? And he said, I take them all at night. And I said, how many times are you up in the night peeing? And he said, 6 or 7. And I said, how good's your sleep? He said, terrible, because I'm up peeing 6 or 7 times a night. And I said, well, I know why. And he looked really surprised. I said, you're on a diuretic, which is a medication that makes you pee. You're supposed to take it in the morning.
See, I'm not alone.
You're not alone. And that guy.
There's two of us.
But we switched his medicine from night to morning. And this guy was on multiple sleeping tablets, all kinds of stuff. His quality of life was terrible. That one small change, everything changed. He's now sleeping through the night. He's now getting proper rest and recovery. So his pain has reduced. He's got more energy. His mood has lifted because he's sleeping well. That one small
Slight change.
This might make you feel good as well. When we were doing one of our cohorts studying at Brightly, and we were inquiring as to the medicines that people were taking, this one guy was doing your wazoo, the wazoo, taking it at the wrong time. But his partner was a nurse, and she was administering it. So I'm like, I wonder actually what that means.
And, it's complex. Medicines are complex. And it's okay to not know. Use your pharmacist that you see. The second thing I would say I want people to know about their medicines is you need a relationship with one pharmacist. You need to go to the same pharmacy regularly. And that's because if that pharmacist knows you and knows what you're supposed to be on, if something comes from a specialist that doesn't match with your usual meds, or there's an error in the script for whatever reason, things happen.
They'll pick it up.
They'll pick it up. If you're going to multiple different pharmacies all over the place, there is no one with your back. There's no one checking that stuff. So have a relationship with that pharmacist. And a good pharmacist also has a relationship with the local doctors. And if they're not sure about something, they will ring your doctor and have that conversation for you. If you say to them, can you tell me what the side effects might cause, what side effects this medicine might cause? And then you think, well, that sounds like me. They could either send an email on your behalf, or they will encourage you to go and talk to your doctor about it and maybe give you a printout to take with you, or, so use the resources you've got available. Ask questions, inform yourself, get empowered, get knowledgeable.
How often should you do a review?
That very much depends on you as a person. And if you're on a lot of complex medications, an annual review is recommended. In fact, in rest homes and retirement villages, and it's written into the contract that patients need to have a 3-monthly review, because that's how often they need to be checked on, and at least once a year a deep dive sort of medication review. And I think that's true for most people particularly people on 5 or more medicines. If you're only on 1 or 2 things, perhaps a chat with your pharmacist and a once-a-year appointment with your GP just to say, is this still all right for me? What are we doing here? Is this still necessary? That should be enough. But it really does depend on the complexity of you and your health and how often your health needs are changing. And if you're seeing lots of different specialists and things are changing all the time, we're going to need to keep a closer eye on it.
Well, fantastic. Amazing to have you here to explain, what a clinical pharmacist does.
Thank you for having me.
It's just great.
It's great to try to get the information out there and just let people know, ask questions, We want you to ask questions.
Yes. Good stuff. Thanks, Judy.
Julia, thank you for the insight and joining us today. Now, if this resonated with you, Brightly can help. We look at medications as part of the bigger picture, alongside your health goals, mobility, lifestyle, and risk, so things don't just slip through the cracks. You can find out more at agebrightly.co.nz.
And if you do know someone who's juggling a lot of medications or who might benefit from hearing this conversation, please share it with them.
Thank you for listening to The Next Bit, because ageing well isn't about just taking more pills. It's about making sure the ones you are taking are actually helping.
Look forward to seeing you next time.